Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In our PrEP Talks series on overcoming barriers to PrEP engagement in principal populations, our episode today focuses on PrEP uptake and transgender individuals and racial and ethnic minority men who have sex with men. Joining me are Kenyon Farrow and Raphael Landovitz. Kenyon Farrow is a Vice President of Policy at Point Source Youth and a contributing author at thebody.com. And Raphael Landovitz is a professor of medicine at the David Geffen School of Medicine at the University of California, Los Angeles. For the full online educational program, including video roundtables, downloadable slides, and other podcasts in this series, please visit the link in the show notes for this episode. Now, it is my pleasure to hand things over to Dr. Landovitz.
Thanks for joining us for this podcast. I really want to ask you, when we talk about the rates of new HIV diagnoses in our Black and Brown communities here in the U.S., where have we fallen short, and what can we do better? What do we need to do better, and how do we do that?
Yeah, so thank you for the question. So I think when we're looking at just kind of broadly the HIV rates, particularly among racial and ethnic minorities, Black and Brown folks in the United States, and we've fallen down on a kind of a number of places. I often think about, what's happened in terms of the science in the last, roughly, 10 to 12 years, which should have been kind of groundbreaking discoveries that really help drive down, the HIV diagnosis rates writ large. So I think often about one, the HPTN 052, where we, discovered essentially like undetectable equals untransmittable, right, through that research. And about a year later, PrEP was the first drug for, pre-exposure prophylaxis was approved. And then a few years after that, the Temprano or START study, which showed that people living with HIV who should get treatment as soon as upon diagnosis, as opposed to waiting until the CD4 count diminishes before people start treatment, as we used to do. So, when you think about like those three sort of scientific discoveries, we should be in a very different place than we are, kind of 12 years later, where we still have, ultimately driven down rates more substantially among whites in the U.S. than we have among anyone else. And in fact, have seen, rates really sort of stagger, particularly among Black men who have sex with men, Black trans women, and also seeing increasing rates among Latinx men who have sex with men and trans women. So I think that first paints the picture in terms of like, we have the actual tools. Now the question becomes, what are the issues that are stalling our success? So first and foremost, I think that from the vantage point of, kind of more behavioral issues, is really that stigma is still very great in communities about HIV. You see it a lot online, that people are still walking around with, really information about HIV from roughly when Magic Johnson disclosed his HIV status, right? And then sort of people might have heard about the cocktail drugs, right? And that's kind of it, right, in terms of new information. So I think we have a stigma problem that I think is in part also an information problem. So we still have such low, sort of health literacy in this country, but specifically to HIV. When I talk to people about, viral suppression and U equals U, and people's heads explode, right? And then when I talk to people about, that PrEP exists, we're getting a little bit better on that front in terms of information. To the extent, like, I always can kind of gauge, because my family knows that I work in public health. So when I have cousins and nieces and nephews and people reach out to me and be like, well, I saw this commercial that was about this drug that'll prevent HIV. Is that real? That lets me know we're getting someplace, but I think we still have some of those issues. And then I think just the bigger story to me is just the impact of the states that didn't expand Medicaid. And we've seen time after time where having comprehensive health coverage actually lowers HIV rates in states, right? There are a number of studies that are demonstrating that. We saw it in Louisiana, right, which New Orleans and Baton Rouge have always gone sort of, back to back in terms of first and second in terms of HIV rates in the country among U.S. cities. But we're seeing rates decrease in Louisiana when they expanded Medicaid. And so I think that the states that haven't expanded also are the places where more Black and brown people in the United States live, and the places where HIV rates are the highest. So I just think, to me, there's both sort of issues around sort of stigma, information, et cetera, in communities. And then there's also the issue of just the lack of healthcare infrastructure in the places where it's needed most.
Yeah, thanks, Kenyon. Those are all such really critical points. I think as providers and public health people, we often wring our hands when it's politics and health systems that are failing us. And it's certainly, I think, a big call to advocacy, right? I think that's one thing we as healthcare providers and public health invested people can do, is really encourage people to get involved in the process, encourage people to go out and vote, and make the critical nature of these things like Medicaid expansion and HIV prevention services that much more in the forefront of people's mind when they have so many other priorities. What I worry about, from a provider level interaction, is we still have such a problem in this country with rampant racism, sexism, homophobia, transphobia. And that, of course, all feeds into the stigma you're talking about. But, in clinical settings and with your experience from PrEP for All, what are the things that our colleagues who are providing care in clinics need to keep in mind when we are able to engage with people despite all these political and operational barriers, to make sure that we're doing right by folks despite all these seemingly insurmountable barriers?
Yeah, you raise a great question. And you're absolutely right that, from the provider perspective, your practice as a provider cannot solve, racism, transphobia, homophobia, homelessness, right? Stigma, all the things in a grand scale. But what you are in control of is the experience that people have when they enter your practice, right? And so for me, when I think about what's important for providers to know is, one, how do you create an environment where people feel, kind of welcome, where people feel open and able to sort of talk about their, issues. And sometimes it just can be what kind of, sex they're having or want to have, and what are their goals and aspirations in their lives, right? That then you can back into a conversation about whether someone has not been tested for HIV or STIs, or may be interested or might be a good candidate to start PrEP or to start ARV therapy, should they, if they're in fact living with HIV. And so I think first we have to think about what the kind of clinical environment and every touch point, from the receptionist, the time people walk in the door, to, the actual interaction with the providers, really matters in terms of whether people will engage in care, whether it's preventative or treatment, right? So I think that's, kind of first and foremost. The other piece of it is, once people are in care, we know that there are lots of kind of administrative sort of barriers that are in place that make it harder for people to stay in care, whether we're talking about people who are living with HIV, who, if they don't have private insurance, and then they have to worry about, kind of consistently filling out paperwork to do income verification for Ryan White or this, that, or whatever. Those things are actually not just sort of taxing on the individual to kind of always have, this sort of paperwork in place in order to move things, but also it actually is just a demeaning process for a lot of people. And that can just become a kind of a mental health barrier if I always am sort of treated like, a ward of the state, right? Or like some sort of social problem because I can't afford these very expensive medications and care on my own. Those things become a problem. So as much as providers can sort of expedite those sort of administrative barriers as much as possible to help people navigate those systems, that's really important. It's increasingly important, especially when we talk about PrEP, because we're talking about, people who are going to have to ultimately engage the healthcare system almost as if they have a chronic condition when they don't, right? So the motivation is different. And so the more we create space and flexibility and a better sort of one-to-one relationships with providers, the better people will stay engaged in care, whether we're talking prevention or treatment.
I think they're such critical points that you make. I'm just taking a step back for a second. And, we do have patients both on the prevention and the treatment side, going through all of these hoops and these gymnastics to document their income status and their employment status and their insurance status, and how much that contributes to stigma and barriers, right? Because it's not like people don't know that they're struggling with employment or finances are limited and are pulled for multiple priorities. But making people reiterate that time and time again can be tremendously harmful to mental health. And I think we underestimate that and need to figure out systems to help with that. I think that's a really underappreciated point. So thanks so much for bringing that up. I love your points about the importance of these one-on-one interactions and how impactful any given interaction can be. When I think about my clinic, I know a lot of the faces that we have, in our front desk and our medical assistant intake staff aren't representative of some of these communities that we want to make feeling welcome in our clinics. We don't have a lot of Black and brown people. We don't have any trans people on our staff. And how important is that representation?
I think the representation is very important. So I think in so much as providers, whether they're in public settings or private settings or whatever, really need to be thinking about the diversity, equity, and inclusion of it all in terms of how, staff that they hire. And increasingly, as, the HIV field has gotten more sort of professionalized, the harder it is in terms of for folks who may in fact be from communities that are most impacted, may themselves be living with HIV. It's much, much harder for folks to then be able to access employment when in a lot of cases, the sort of HIV field is the first entry point. A lot of poor and working class, especially LGBT folks and LGBT folks of color, have in terms of being able to get into, a kind of career path, right? So, and so I think we have to think about what experience and what qualifications look different than just hiring, frankly, a lot of 23-year-old white women just out of undergrad or just having an MSW, right, at 24, 25 years old. And think about, people who, maybe don't have those credentials, but who know the community, know, the sort of issues that folks are coming with and and have a different set of relationships. Now, that's one piece. That is not to say that people who don't look like people who are from the community can't also serve and be sort of, culturally competent in the way in which their care infrastructure is set up and the relationships they have with their staff. My provider is a white, Jewish, lesbian woman, and I will not give her up for the world. As long as I live in Cleveland, Ohio, and she's here, she will be my provider because she, we have a good relationship and she just generally has a good relationship in the community with other folks that she sees right around PrEP or HIV treatment. So I don't want people to think that if I'm not Black or not Latinx or I'm not trans or not gay or whatever, that you can't serve communities with integrity and in ways that people respect, right? But it also means that you should also look at the rest of the staff, right, and think about ways to better recruit and retain, folks of color and LGBTQ folks in the process.
So Kenyon, let me ask you very specifically, and so this provider of yours that you have such a great relationship with, what is it about her? What is the cultural humility that she has that allows that relationship, not only with you, but with the community in general, to be so successful? Is there anything you can point at, or how do people who are wondering how they can be a better ally, or if they don't come from community, have that cultural context, sophistication, appropriateness, humility with their clients and patients?
Sure. So for the first time I saw her when I moved back to Ohio, to Cleveland from New York City 3 years ago, and I was looking for a provider, she came with great recommendation. My first actual encounter with her, she walks into the office and she sits down and she says, what should I call you? Is Kenyon fine or whatever? So the first thing was, how do you want me to relate to you? I was like, yeah, Kenyon is fine or whatever. It also, in that instance, turned out that we know people in common. So we sort of were able to talk about that. But we also, but she sort of talked to me first about hey, I've been, in Cleveland, doing, HIV care and PrEP care for X amount of years. I lived in Chicago. And, we sort of talked. She talked to me about her own story. And so I knew a little bit more about her, disclosed that she was a lesbian, so I knew a little bit more about her in that conversation first. That actually made me feel more comfortable in terms of opening up. And I know typically, and I'm not an MD, but I feel like people probably get trained to sort of maintain more of a kind of a distance, right, between patients. But sometimes I understand that from a certain kind of professional level where you do want to keep some sort of professional distance. But sometimes that distance ends up being a barrier, right? It feels like not like you're talking to an actual human being in person. And so it was just really the fact that she asked me a lot of questions, not just about my sexual history or life or what I'm doing, but just, the kind of work I do, where in town do I live, learn more about me as a person, the things that I'm interested in the world. And then got into the more discussions about, my own sexual health, how long I've been on PrEP, et cetera, right? And so that has made all the difference in terms of then when I feel like I need to go to her with questions or whatever, I feel far more free to do that than in situations where I've had other providers, even doing this work. And I've had a couple of instances over the years where I've said to providers, if I didn't do this work, I would not return back to this place. Or if I, in case I remember being in New York at a place and I went to get an HIV test, and I'm saying to the provider, if I didn't do this work, I would leave here and not wait for the results. I'd walk out this door and never come back, right? And so I think we have to really think about, the dynamics with my provider, I think really just in terms of demonstrating herself as a human being, as a person, talk to me about my own interests in life as a way to connect has made our care relationship that much better.
I love that because I think that's a really important take-home message for people who aren't from community about just being a human being and recognizing that you're sitting in the room with another human being first goes a long way towards establishing a relationship that's going to be therapeutic for everybody. And we're kind of at the end of our time together, but let me just ask you, when you provided that feedback in New York, when you went to that clinic for the test and it sounds like it was not a good experience. I think that's probably the nicest way I could characterize that from what I'm reading between the lines there. Did they hear that feedback or were they like, it is what it is, goodbye?
They did not hear that feedback well. I think they took it as me being kind of a pushy know-it-all and not actually, and I said to them at the time, this was like a while ago, this was like pre-PrEP, right? But in like the mid 2000s. So they weren't actually quite that responsive to my feedback about the interaction and some of the levels of judgment from the provider and kind of weirdness. So they did not. Now, I think that things in general, especially given the work I think that happened in New York, I would probably say starting with, Dr. Bassett as the commissioner and then with Dr. Daskalakis and Dr. Blackstock, when they were both in the New York City Department of Health and Mental Hygiene working on HIV, I think they did a lot of work to really engage providers around the city to sort of better serve LGBTQ folks, people living with HIV, people on PrEP or wanting to access PrEP or whatever. And so, you have to, think about those sort of dynamics, like the role that health departments and training and things can do sometimes also to help sort of transform the way, most people will engage care by doing some of that education work with providers themselves.
Yeah, they really did amazing work in New York, right? And of course, Dr. Daskalakis now, part of the White House MPOX response and continuing that work, and Dr. Blackstock continuing on in New York. It's so exciting. We're so lucky to have both of them as public health officials. Kenyon, I just want to thank you so much for chatting with me today. This is so important. I think really highlight some really critical points for our colleagues who are doing and thinking about doing this work on how to provide HIV treatment and prevention care to all of our populations, both with HIV and at risk. And hopefully it's going to be food for thought and spark some ongoing conversations in some of these clinics about how they can do better given even limited resources. So thanks so much for chatting with me today.
Oh, thank you very much.
Thank you very much to Kenyon Farrow and Raphael Landovitz, and thank you to our listeners for joining in. As a reminder, to view the full Path Forward in PrEP, Overcoming Barriers to PrEP Engagement in Principal Populations program on the CCO website, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.